doctors speaking out with science. I'll ask them to introduce themselves to you. Dr. Goodwin.
Right, hello, yes, I'm Dr. Alison Goodwin. I've been a doctor for over 30 years now. First 10 years or so were in emergency medicine. Then I started general practice in 2009. I've been a fellow of the College of GPs since 2015. In 2019 and 2020, I was studying lifestyle medicine to learn more about how powerful nutrition or optimising nutrition, exercise, sleep, etc. were for reversing and preventing chronic disease. I had concerns in 2020 about the whole COVID pandemic.
I'll just pause you there, and we'll let Dr. Shelton introduce himself, and then we'll move on to the issues that we're here to talk about today. Dr. Shelton.
Yes, thank you. So I'm Matt Shelton. I'm now in my 40th year since graduating, and I've been a fully and consecutively registered doctor until 3 years ago. I started off originally in general practice and then moved fairly quickly into anaesthetics and intensive care, and came out here to finish my training, but got caught up in international medical politics, and found on the first day of work that I had to go right back to the bottom of the scale, so I chose not to do that. And went back into general practice. I've also trained in nutrition and environmental medicine and have a fellowship in that, and taught mostly doctors at a postgraduate level for ACNEM, which is the Australasian College of Nutrition and Environmental Medicine, based in Australia, for 12 years, up until 2018 or 2019.
Thank you. Now, New Zealand doctors speaking out with science, or as it looks better in letters, NZDSOS. When did the group of people involved in this organisation begin to form a group?
Well, we began having discussions, some of us in 2020. We shared concerns around what we were observing, but we formally kind of coalesced Easter 2021, around about the time that a High Court challenge was being made around the legality of rolling out the vaccine to the entire population, where Section 26, I think it was, of the Medicines Act, was specifically about a provisional consent medication only being available for small numbers of people. So, and Alison actually wrote an affidavit for that case. So we really formed to support that process, and to send a letter of concern to the Medical Council and relevant decision makers.
Can I just check on those dates there? I think you said you formed in early 2020 when COVID first arrived. Is that correct?
April 2021.
2021.
April 2021.
My mistake,
okay.
sorry.
Yes, it was the provisional consent under Section 23 of the Medicines Act.
Why the group was formed. All right, thank you very much.
Yes, it was Plan B in 2020. So some of the doctors sort of were supporting Plan B or interested in what Plan B was saying in 2020. But then we formed you guys formed your own group in 2021 to support the court case.
All right. And the group that formed, where did its members come from?
Broad range of backgrounds. We had specialists, we had GPs, we had some people who had already known each other through integrative medicine, which includes things like nutrition. So we had some psychiatrists, an anaesthetist, gynecologists, GPs. So it was from across the range of specialties.
Right, but also dentists, vets and pharmacists, as well as medical practitioners.
Yes.
Thank you. So you formed specifically in relation to the vaccine. Can I just take you back a little bit further? As medical specialists, do you accept that COVID-19 in New Zealand in 2020 was a potential outbreak of disease requiring a serious public health response?
Yes, absolutely. In fact, I signed a letter very early on in 2020 to the Prime Minister asking her to consider seriously closing the borders, not locking down the country, but closing the borders whilst more information was coming. This was very, very early on. And subsequently, I felt much more reassured as information emerged about actually how similar this was in lethality to the type of influenza that I've worked through numerous times in my career.
And Dr. Goodwin, what was your position about the earlier preventative measures, the elimination measures taken in 2020?
In early 2020, yes, I thought it was reasonable perhaps to shut the borders and pause things to assess what was going on. But it was evident fairly early on that, as Matt said, it was an influenza, moderate influenza level illness. The average age of death was 82, and a small select group of people that were identifiable were most at risk, and the majority of the population was not at significant risk. And that was evident early on in 2020. And then I became increasingly concerned during 2020 about the response and the harm that was being caused by the response.
Which deviated considerably from standard pandemic principles that existed before that I wasn't across until I took the trouble to find out. But certainly, lockdowns, social distancing, masking, none of that, had an evidence base. You identified people who had showed signs of illness, and they would isolate at home. But the pre-existing thing was you maintain normal life, and the community is best served by going about their lives as normal as possible.
Well, yes.
I
was going to say fear and unemployment have health consequences and medical consequences, and nobody seemed to be taking that into account.
Do you accept that there were scenes on television from overseas, from Italy and from the UK and the United States, of something significantly worse than a seasonal flu outbreak?
There were some horrifying scenes very early on. Images from Wuhan, particularly. The first centre, and there were hotspots certainly in northern Italy and New York. But a lot of those were later regarded as certainly the Chinese ones as propaganda or fake or sort of fear generation. And we're not saying that there wasn't an illness that was very severe in some people, but we've been doctors all our lives, and we've worked through every winter there's a flavour of the month or several flavour of the month viruses that can carry people off, sadly, whose immune systems have aged with them. But there didn't seem to us to be any reason to depart from the way we'd always worked, and we can refer back perhaps to the swine flu, which is the most recent one in our memory.
We don't need to go back. So from your perspective, at least you, Dr. Shelton, this was just another winter at the office. Well,
no, there was a lot of fuss about it, and it was clear to me and some of my colleagues as well that it was the origins were suspicious, and I think these days nobody doubts that it originated from the Wuhan biolab, the Institute of Virology, but anybody at the beginning who asked about this or raised questions was of course labelled in the usual way.
Right, thank you. And Dr. Goodwin, the deaths that we saw overseas, do you consider that was a variation on a typical flu season?
Well, I have to say I wasn't particularly, I don't watch TV, so I wasn't really watching what was on TV and what was being shown in early 2020, but I wasn't unduly concerned. I thought, this will be something that'll pass quickly, and I wasn't worried. But yes, I wasn't sort of looking at the propaganda, looking at the scenes on the TV. So at that time.
Do either of you, do you dispute, and I'll ask each of you, do you now dispute or accept the widely held view that the pandemic caused many deaths worldwide before the vaccine was available?
Well, any death is regrettable, so you'd have to define many. And there's certainly been questions raised all the way through about how do we determine dying with COVID, dying from COVID. Certainly people have died, but the relative, numbers, it's very important to try and separate, emotion from actually what the hard numbers say. And there was significant backtracking by authorities, particularly in the UK, Italy, and the US, where they all later revised down the numbers based on, looking at comorbidities. How many people who were otherwise healthy with no comorbidities actually died. And people treating physicians who were treating people, especially in the hotspots like New York, we're saying clearly this is an unusual illness. It is significant, but we are seeing dramatic reductions using early treatments. And as GPs, that was very exciting to us because we're keen in the front line, to do what we can. So we're not saying that there hasn't been a significant illness that has certainly killed some people.
So if we turn to the vaccine, and you will both have had wide experience with vaccines throughout your practices.
I've been vaccinating my whole life as a GP.
Dr. Goodwin?
Well, yes, it's part of a GP's work. More to discuss, perhaps, with the parents. The nurses probably do most of the administration of vaccines, but yes, to discuss with the parents, particularly when the babies come for their 6-week checks.
And you would understand that from the point of view of MedSafe, whose job it is to approve a vaccine, the benefit risk assessment is the question to be asked, isn't it?
Well, usually it is, but we've had multiple concerns that we've written about, including in our substantial evidence to you, and on our website, NZDSOS.com, where we've there are many posts, but also significant open letters where we've listed all of our concerns all the way through with evidence. And for a, and I have to disagree that it's a vaccine. It's more properly described as a gene technology. It is very, very different. It is not a traditional vaccine. And calling it as such risked sidelining perhaps a doctor's natural inquisitiveness or instincts. The clinical trial was for 2 months. There was no long-term safety data. Not a single physical vial of the injection passed through the Ministry of Health or MedSafe, and I've heard that from several sources within those departments. So it was a paperwork application, and it wasn't considered safe enough, actually, that MedSafe would approve it. They weren't happy with the risk-benefit ratio, which is why they passed it on to a Ministry of Health committee called the MAAC, the Medicines Assessment and Advisory Committee, which did then tell Pharmac to issue a provisional consent. Now, that's different from a fully registered medication, so it did not go through the normal processes.
The MedSafe concern at that point was that there was evidence of only limited protection from transmission at that stage, wasn't it?
Well, they actually had 58 concerns, actually.
No, they imposed 58 conditions, didn't they?
Well, they asked 58 questions of the drug companies that still needed to be satisfied, so they asked for more information. Yes, they did.
Yes, but do you agree that the decision was referred to the committee rather than made by the MedSafe authorised person himself because of the concern that the efficacy at that stage seemed to be limited to maybe only 2 months of protection?
Well, there were a variety of, with the risk-benefit assessment, you're weighing up the risks, the safety of it. Is it safe? And they had only 2 months of safety data from the Pfizer trial. And then the benefit. And the benefit, although we were told it was 95% effective, that is the relative risk reduction, and the absolute risk reduction was 0.84%, and that is the number that should have been explained to the population of New Zealand. So the efficacy that they were saying with 95% was based on the outcome of just 170 patients out of the 44,000 patients in the clinical trial. So 95% efficacy is a true number, but it's a relative risk reduction, and it's a misleading number, and MedSafe was aware that the efficacy was not 95%.
And they had identified, you're quite correct, they identified that the clinical trial was not powered to assess transmission, and it became fairly evident very quickly that it didn't stop transmission, it didn't stop people getting COVID anyway, and that was predictable from first principles of immunology and vaccinology, actually.
Is it fair to say that at the time the decision was made, the benefit of the Pfizer vaccine was expected to be both personal health benefits, that you wouldn't catch the disease, and the public health benefits of fewer people catching the disease and so less impact on the health system?
I think that was the expectation by the community at large, and as propagated by the government. That certainly was the messaging, and I think that was what people were intended to take away. And I sensed that the 95% was sort of Swedish rounded up to 100%, or supposed to be, in people's minds, to 100% effective, because 95% is nearly 100%, and that they also projected this onto the safety as well.
But
And I think that was the intention of the messaging to the
coming
people.
back to the decision made by MedSafe, do you accept that it was made with those intentions in mind?
Yes, there was wishful thinking that it would prevent infection of individual people and that it would prevent transmission, but the data did not support that at the time they approved it. And Chris James wrote, the risk-benefit assessment is not clear. And I cannot approve this. I mean, that's not quite the right words. I cannot approve it. But he declined to approve it himself and referred it to the MAAC committee.
So were you aware by February 2021, when you came concerned, that other countries had used the vaccine as part of their COVID response?
Yes.
Yes, it started in December 2020, the rollout in other countries. So yes, there were 3 months of data. Israel in particular had used the Pfizer vaccine exclusively. So there was data coming in from Israel, there was data from the UK, more about the AstraZeneca though.
And the US.
And the US.
Was your website running at that stage?
Not immediately, no. Our first activity was an open letter, and there were several back and forths. So we were mostly active in email threads. I can't remember when our website went up.
It was
would have been within a month or two.
Yeah, May, April, May, June. May, June 2021.
And did you become aware that while you had concerns, other groups, other individuals were satisfied with the reasoning that MedSafe was relying upon and that the health advisors for the government continued to rely upon?
Well, we were having some communication with one or two of those health advisors from the beginning. We got one response to our first open letter from the Chief Medical Officer, and that was really it. But clearly the population, and that includes within the population, doctors and many other people, were clamouring for relief from a year of, being imprisoned in their homes on and off, the chopping and changing of the instructions. And I think it's very reasonable. And I've noted this week, and I have a lot of sympathy with people who say that they trusted the government and they really wanted somebody to do something and they wanted it all to go away. Now, that doesn't mean that what was done was correct, but it's a laudable and understandable instinct. The question arises, could and should the government have made better decisions? And this has been our issue all the way through.
I'm not asking you about what the people receiving this advice from government thought. I'm asking you about the people that were advising government that had views different to yours. Do you accept that they held those views genuinely based on the same data, the same avenues for information that you were looking at?
It's hard to know because it was impossible to have a conversation with them and ask and discuss things.
And they certainly didn't look at the data that we provided or answer any questions to reassure us or explain to us why we were wrong and why we shouldn't be concerned. And that's been the unifying theme all the way through, I have to say. So.
Right. Did you begin to have concerns about guidance being given to doctors about how to deal with patients arriving for vaccines?
Yes, absolutely. In April 2021, the Medical Council issued a guidance statement to all doctors, the 28th of April 2021. A guidance statement that's, the effective message was that thou shalt be vaccinated yourself. You shall promote the benefits of the vaccine. There was no mention of the word risks. And there is no place for anti-vaccination messaging without a definition of what anti-vaccination messaging would be. And to me, that completely contradicted the existing 8-page document the Medical Council already had on informed consent, which says you must speak about the benefits or potential benefits of a product, but you must also speak about the risks, the uncertainties, the things that we don't know, and the alternatives. What else can you do? None of that was mentioned in this guidance statement, and as it's played out, talking about risks, uncertainties, alternatives fits into this anti-vaccination messaging in our experience.
We had medical legal guidance too that, I'll paraphrase, clearly in the context of an experimental vaccine with limited safety data, explaining this and that there is no long-term safety data is the only way to proceed in the context of an informed consent consultation.
Do you accept that the perceived public health risk is a relevant factor and something to be discussed with patients?
Yes, and the risk was overblown. Most people were scared witless. I mean, one of the young people yesterday left her job and raced back to Northland because she was so scared of COVID. She was not at significant risk at all, and so people had an overblown sense of their risk. They weren't being told, actually, if you're under 20, under 50, you'll probably be fine. You're not going to need any treatment or anything. And the other thing that was missing was treatment. People were under the impression there was no treatment. Well, that's just absolutely not the case. GPs are the experts in treating viral respiratory illnesses, but GPs weren't part of the equation. They weren't being questioned. They weren't being asked what they were seeing. But yes, people were frightened, very frightened, and unnecessarily so.
And treatments we could have used, based on reports from treating doctors overseas and emerging clinical evidence, properly conducted clinical trials, were taken out of our hands, and doctors were censured or frankly punished if they tried to import them or use them for their patients.
Is it fair to say that your views on the scope for risks with the vaccine were heavily influenced by your understanding that there was not a serious public health risk with COVID?
For me, that was part of it, but there were many other things, many other alarm bells, or red flags, if you like, deviations from normal practice, particularly the communication channels within the profession, and the very polarized and obviously sort of fear-based sort of psychological influences that shut down the ability to have reasoned conversations, and particularly to discuss, clinical and scientific issues. All channels were blocked, and the abrogation of medical ethics, the inability to have questions answered or to discuss negative or concerning data, all of those things were very relevant to our assessment of what must be going on. And it seemed to us there was more at play than, a moderate, mild to moderate cold to influenza type illness that most people experienced. So yes, we were skeptical and critical, and worked harder to try and understand what might be at play.
And as Matt said, it's not a traditional vaccine. It's not a vaccine in any sense of the word that the public would have understood a vaccine to be before. We were injecting synthetic genetic material into the human body to make our own cells make a foreign protein. That's not how a normal vaccine works. And there were also lipid nanoparticles as well. So there was enormous potential for significant risk. And nobody seemed to be discussing, as Matt said, there's no forum for discussion or ability to get questions answered about these new things that were being used.
Thank you. I'm going to come on to adverse effects, adverse reactions that you observed and what the processes were for dealing with those. But just before I do that, Dr. Goodwin, when you gave evidence to the Commission a week or two ago, you spoke about particular concerns with giving the vaccine to pregnant women. Mm-hmm. And my question is, what was your understanding of the effects of COVID on pregnant women?
Well, the public messaging was that...
No. What was your understanding as an expert who was involved in these areas of the effects of COVID on pregnant women? And right, you would have been looking to overseas because it wasn't really here.
Well, yes, that's right. I mean, I wasn't getting clinical experience with it because we didn't have COVID in New Zealand. So the reports from overseas were that it was significant. But again, I'm still waiting for the New Zealand science in particular to back that up. The pregnancy study in New Zealand that was looking at COVID in pregnancy and then added COVID vaccination, I mean, it hasn't published any data 5 years into the thing. So it's hard to get hold of data to actually back it up. I mean, the messaging, yes, was that COVID was deadly in pregnancy or serious in pregnancy, but, hard to find the data to back that up.
Well, there didn't seem to be any reliable data. And in fact, since then, there have been large studies, refuting that it's not a particular risk, and that unlike influenza, which can be more of a risk to younger people, with functioning immune systems, COVID remained a risk mainly of the elderly and comorbid. And anyway, still the risks of using a brand new platform, well, it wasn't brand new, the platform itself, brought with it significant risks. There's never been a single fully approved mRNA platform product ever. The absolute golden rule, the red line that you never ever cross, unless you're an extremist, that you don't expose pregnant women and their babies to risk. And this is a pragmatic thing. This is about the future of humanity.
What about the risk of
should
COVID?
Have trumped. We already knew what the risk of COVID was, and talk of it being potentially dangerous in pregnancy, wasn't backed up and wasn't borne out, and there were treatments.
It's treatable. This is the thing that's missed from the whole thing. It seems COVID or vaccine and all the spectrum of treatment in the middle is forgotten about. So, most pregnant women would have needed, the standard GP advice: rest, take fluids. And it'll get better. If you need something more, then there are treatments. I mean, you could also have ensured the vitamin D levels were adequate in pregnant women. I mean, in the whole population as well, because that had a association with lower seriousness of the disease. If you caught the disease, if you had adequate vitamin D levels.
There's a standard recommendation for the flu jab, for instance, which is, a known quantity and has been around a long time, that pregnant women may benefit from it, but it's certainly not mandated. It's never coerced.
Just to come back, Dr. Goodwin, to your first answer, there was evidence relatively early on that COVID was a cause of complications in pregnancy, wasn't there?
Well, I mean, I didn't specifically see that, but again, possibly.
So just pause. You would have been looking for that, wouldn't you, in your concern for pregnant women getting this vaccine?
We heard, but along with that, there was messaging that was also, there was plainly inaccurate messaging that was fear-based, didn't match standard practice or evidence that was emerging. So around that time, there was talk of things like myocarditis and pericarditis being vanishingly rare, when in fact the reporting systems that we have, which are all universally accepted to underreport, sometimes quite dramatically, were flagging significant adverse effects and in fact deaths. And even before the first vaccine was given here in this country, there were signalling systems going off overseas that our regulators would have been aware of, the government would have been aware of, and ought to have looked at. And all we heard was, there's nothing to see here. Or rather, we're not seeing anything that we don't expect to see, which was a slightly sinister and twisted statement, I have to say. But we will continue to monitor. And so there were far greater concerns than any sort of theoretical risk. And certainly there wasn't a report in this country that pregnant women were dropping in droves from COVID when it did come in. But as doctors, we know that all infectious diseases can potentially affect the maternal immune system in unpredictable ways or ways that are different. But I certainly didn't get the impression, despite some of the messaging, that it warranted taking the risks of a new treatment into pregnant women. And certainly some, especially border workers, there were some that we knew of who didn't want to take the vaccine, but who were pregnant and who took it to keep their jobs. And that's untenable, in my view, from a medical ethics point of view.
Were you aware of studies showing that myocarditis was also a real risk factor from COVID?
There were studies saying that. As time's gone on, it's become clearer and clearer that this notion that COVID is more of a cause of myocarditis and it's more severe is frankly rubbish. Large literature reviews, narrative reviews, assessments of the broader landscape, and the real-world experience of doctors all around the world, including here in New Zealand, which, as I know, all you can look at, would actually say otherwise. And of course, we've included plenty of evidence in our written statement to you.
Well, yes, and I did an OIA because I was curious about that very question about, we were told that myocarditis was more severe in COVID than post-vaccination. So I asked the Ministry of Health, well, how many cases of myocarditis due to COVID infection have they been? Well, they couldn't provide me with a single case, and yet there were 900 plus cases of myo and pericarditis on the CALM safety report 46. November 2022. So
I don't want to get into all the detail of all your submissions, but your request for it was of cases of people with COVID and myocarditis in hospital, wasn't it?
Well, myocarditis is a fairly severe disease, and most people who are properly diagnosed will likely spend some time in hospital.
Yes, but your Official Information Act request was of people with a COVID-19, was with COVID-19 and myocarditis, wasn't it? In hospital.
Well, yes. I mean, it doesn't say there weren't any, but there certainly weren't vast numbers of them if they couldn't sort of identify a single one for me, as opposed to the 900 cases following the vaccine reported to MedSafe in the first 2 years.
All right.
And I mean, it depends how you diagnose myocarditis. Is it just a transient troponin rise in an acutely sick person, or have you got an ECG with changes, an echocardiogram with changes, an MRI with changes? You know, it depends how you diagnose.
Do you accept that on all these issues, and I mean all the issues that you have put in the submission that you've given to the Commission, there are experts with differing opinions?
Absolutely, and I would love to speak to some of those experts, but there has been a brick wall between the people that have different opinions.
And the other point here is that opinions, especially strong ones, high-level ones, need evidence. And one of the deficiencies we identified early on was a parade of people making statements in the media without mentioning a single study, but just trading on the fact that they're from the government,
and
we should trust them.
Yeah.
Are there any positions that you've taken on some of the scientific issues that you've then wound back from over this course of a couple of years, 4 years?
I'm really having to dig around, our view, and I would perhaps just backtrack to who we are. I mean, there's now around about 300 of us, the majority of whom are medical doctors. So we do peer review our views on things. We try and triangulate, and we're constantly trying to find evidence that we're wrong. And in fact, we're more concerned now about graver safety issues, some of which we've written about in our submission, than we were at the beginning. So, no, there are some topics that we found there's either no point or have been trumped by other more urgent issues that we need to shout from the rooftops, for sure. But I don't think...
Well, so I'm struggling to think of something, but I mean, I'm happy to have something pointed out if there is something obvious, but...
Can you just list perhaps one or two each, any COVID-19 science issues on which you consider the government has acted on correct advice?
Has acted on correct advice?
Are you including the vaccine in that?
Yeah.
No.
Yes.
I think the initial response to prevent overseas travellers coming in was wise, and that was actually against the run of play, because the WHO was saying that actually it was racist to stop plane loads of people from Wuhan and other places in China coming into the United States, which was also suggested.
Let's just focus on the medical, the scientific evidence.
Well, they presumably felt they had science. I mean, that was perhaps standard pandemic principles. I agree strongly with Dr. Ian Town, who advised the government that children should certainly not be mandated, and that at least, he said, children should only have one dose, based on emerging evidence that myocarditis, especially in teenage boys, was more common after the second dose. And this was initial advice that he gave as the head of the CVTAG in 2021. Now the government, and specifically the then Director General of Health, pushed back on that, and the committee changed its advice. And this has been explored by different people using OIAs and getting the minutes of what went on in these meetings.
Well, yes,
so I think that was correct.
At one stage, a longer gap, to reduce a 6-week gap.
If there was going to be two doses.
Yeah.
I have referred you to a 2024 UK study of the health records of all adults that were vaccinated which shows that the incidence of heart attacks and strokes was actually lower after COVID-19 vaccination. Was that a study that you had considered before?
I don't remember seeing that one specifically, but there's well over 1 million, and I would suspect now approaching 2 million pieces of research that have been published in the time of COVID. So it's certainly possible to cherry pick, but there are a number of questions one has to ask. First of all, what would be the mechanism? Is there a plausible mechanism by which the vaccine would reduce things like that? And there's something called the healthy vaccinee effect, which was identified early and may well explain why the initial data did seem to suggest quite a strongly protective effect in the elderly, but only temporary. And that is that people who are very sick or near death may avoid or not have the vaccination. And that people who are keen to be in front line for the vaccine may already be very health conscious and health literate. But that effect is usually gone after a few sort of weeks or months. And I noticed that study only looks at people out to 25 weeks, but you have to correlate it with what's happening on the ground. And there are, to my mind, or to our mind, far more plausible mechanisms, demonstrable mechanisms for vascular harm, strokes, heart attacks, blood clots, neurological disorders, autoimmune sort of self-attack, including on the heart, and the myocarditis is a good example, than any mechanisms I can think of where the vaccine itself would directly improve the health of the lining of the blood vessels, which is where most of the vaccine is taken up. So, to answer your question specifically about this study, look, it's one of a number that have been hosted on the Ministry of Health website, etc., seeming to say things are safe. But, a rule of thumb, well, not a rule of thumb, a guiding principle in an experimental about which there is limited or no safety data is that if there's any negative data accruing, you stop the clinical trial and an independent safety monitoring board assesses in case this is a signal. So, the headline results of study like these can be quite beguiling or reassuring, but you have to look at the totality of evidence, and you have to be particularly suspicious and on the lookout for data that would suggest harm.
Can
I make one more point? Sorry, just about this particular study. We look very hard to see how they defined vaccination. When you're considered vaccinated relative to when you've had your dose. And throughout 2021 and 2022, there was a whole host of studies published that it turned out used what are called window counting errors. And that was where there was a deliberate misdefinition that you could remain in the unvaccinated group until up to 2 weeks after your second dose. If you had a reaction or if you caught COVID, you were considered unvaccinated. And there were lots of studies that were published that used this, you could say, mistake or this maneuver to appear to show differences, benefits that weren't actually there.
Right, thank you. Finally, the World Health Organization has referred to there having been more than 13,000 million vaccine doses
yes,
in the world.
13 billion, yep.
Do you accept that that is likely to be correct?
I think that's ballpark.
13,000 million.
5 or 6 billion people.
That's a billion, isn't it?
Yes.
1,000
Yeah. 5 or 6 billion people have been vaccinated, and several doses and boosters, and that would be absolutely ballpark. Yes.
All right. Thank you. We are almost at our time limit, so I'll ask the commissioners if they have any questions.
Commissioner Goodwin.
Thank you very much. Dr. Shelton, can I just clarify something with you that you said earlier? Right at the very beginning of your testimony, you had said that that the numbers with COVID, and you talked about the United States, I think, there had been dramatic reductions using early treatments, which you said you were very excited about. And then a little later on, you said, but treatments were taken out of your hands. So could you please just step me through that and explain what treatments and what was taken out of your hands as a medical practitioner?
Certainly. The first manoeuvre was the hydroxychloroquine, which probably has had the strongest evidence, certainly through 2021, for reducing severe outcomes, hospitalizations, death, intensive care admissions, was changed in 2020, I beg your pardon, from being something that GPs could prescribe to special authority was required, or specialist endorsement, I can't remember which, one of those two, which meant that the GP could no longer just write a prescription and hand it over. Then there was it's classified as a herbal medicine called Artemisia, which is actually on the World Health Organization essential medicines list. It's the most effective malaria treatment. It's an antiparasitic in areas of hydroxychloroquine resistance in Africa. So it's a very effective and well-known quantity. And MedSafe, for reasons, the reasons were clear actually, removed it from the shelves and made it a prescription-only medication. Now, not many doctors would have heard about that, but it's quite a staple in often complementary approaches to cancer. And then, of course, there's the whole vexed question of ivermectin, which was previously available under special authority for treating scabies. So it's another antiparasitic. And some strong and exciting and reassuring evidence started emerging, and that's only got stronger. And I'm one of the things I'm particularly in trouble with the Medical Council for, is claiming that there are many good, solid, double-blind, placebo-controlled trials and meta-analyses of those trials where you lump them all together, and that's considered the highest standard of evidence. And by the way, an expert opinion is considered the lowest standard. And that was roundly criticised, and people were put off by it being scathed in the media. And we received a letter from the GP College saying that it was dangerous and there was no evidence for it, and doctors could get in trouble for prescribing it. So it seemed that each time there was an opportunity to get stuck in and actually use something in practice, when COVID came into the country, which of course it didn't really in any significant state until sort of early 2022, really, they were all consecutively sort of taken out of our hands, which was, it was insulting for a start.
And unusual.
And it was unusual. And to be relegated to be heroic swabbers, contact tracers, and jabbers, which I believe was the exact words of the medical director of the GP College, was again unusual and somewhat sort of disabling in our ability to help people. Now, I was suspended by that stage anyway, so I didn't work through the COVID as it appeared. I was busy winning in court and having the court say that the Medical Council should stop their actions against me and I should be allowed to get back to work, following which the Medical Council immediately resuspended me. So again, this deviation from the normal way things are done was just yet another red flag that the imperative to get this injection into every arm had somehow captured all of our institutions, including the Medical Council, which actually took the view that this was a zero-risk medical product, by the way. And so I think that one of our recommendations should be that relationship between government and the political narrative of the time and our institutions should really be examined and needs to be repaired, because there is, a vowed loss of trust in some of our institutions. We hear about it all the time. And I think that's a very important thing to repair, is to get genuine independence back in. And so, yes, it's a source of great regret that we were not able to do our medicine and use our clinical skills and our clinical judgment, by the unique doctor with the unique patient in front of them, and that is the heart of medicine, is that precious relationship.
Can I just, I wanted some further clarification, if I may.
Sure, of course.
So you talked about all these potential treatments that could be beneficial being taken out of your hands. Why do you think that was? Why do you think that these treatments were taken out of your hands?
Well, that's one of the $50,000 questions, and I would love the Commission perhaps to explore that too. Certainly, the Pfizer contracts that have been released elsewhere, generally whistleblown because they're guarded, contain clauses which say that there's to be no competitor treatment. And because early on a decision was made, I mean, as early as March 2020, there was discussion on RNZ about looking for a vaccine. We paid $26 million to make sure we didn't lose out, and that this was to be the centerpiece of our response going ahead. And certainly in the United States and some other countries, you can't get an emergency use authorization for a drug if there are already existing treatments. So that's a legal thing. We don't have EUA, we have provisional consent, but presumably the similar things apply. But you'd have to ask the people that made those decisions, of course. We can only speculate.
Right. And my final question, so are you saying that the New Zealand Medical Council were acting in a kind of politicised kind of way to support government decisions?
That's certainly been our assessment. We do say that most definitely. And medicine has suffered, and our entire profession. Not only did we experience really the first professional mandate via the guidance document, but the very visible sort of silencing and censoring and lawfare, we would say, against people who felt they had no option but to speak out. Our fiduciary obligation, it's not just a duty, it's even higher than that, left us no choice but to try and raise concerns given that we couldn't discuss them or get them acknowledged or told why we were wrong. And it's no accident that most of us are, longer in the tooth. We've certainly had, some younger doctors as well. But, it's experience is very important. I have no doubt that I'd have probably taken the injection in the first 10 years of my career if this had happened when I was younger. But, you can't unlearn things once you've learned them. And if we'd honoured medical ethics, protected BORA, which as far as we're concerned, the Bill of Rights lies bleeding and bruised through all this, and there are a number of other acts that we witnessed, statutes, being sidelined through all this. Our view is that COVID, when it came in, would have come and gone like all infectious pathogenic viruses do over 6 to 8 weeks, as happened in 2009 with the swine flu. And Tony Ryle was lauded, actually, as the health minister back then for his management. And
sorry to
that's
stop
all right.
you. You've answered my question
thank you.
and clarification. Thank you very much.
You're
I
welcome.
need to pass to the chair. I think you have questions.
Yes, I do. You've indicated that you were, Dr. Shelton, you were suspended by the Medical Council.
Yes.
And that happened more than once?
They proposed to resuspend me, knowing that my annual practicing certificate was due. I made a choice that I would rather not have the ignominy yet again of being a suspended doctor, so I didn't reapply for my APC, which meant the Medical Council had nothing to suspend thereafter. So I didn't. So I haven't worked for 3 years. Oh, I've worked my tail off actually, but I haven't worked clinically.
Yes. So you're not
which is a huge
doctor.
regret of mine.
You're not a registered practitioner?
I am registered. I'm on the Medical Council register.
On the register, but no practicing certificate?
No practicing certificate.
Right,
yeah.
thank you.
It was clear to me that the Medical Council were not going to let me work, certainly not easily.
Government would normally take account of decisions by the Medical Council and would regard them as reliable?
They would.
And so, in terms of government decision-making, would you accept it was not unreasonable for them to rely on things like Medical Council decisions and other medical advice that they were given? In other words, decisions were open to government.
Yes. there have to be mechanisms, but sometimes those mechanisms break down, and it certainly seems these ones have.
Understood, but your criticism really is of what happened at a lower level than government decision making. It's really about the advice that was given to government. Am I right?
Look, I don't know enough about what went on to comment. What I know is that we've got spectacularly high rates of illness. We've got an emerging cancer epidemic.
We've got limited time. Just if you can confine your answer to my question.
Okay. Could you ask it again, please?
Do you accept that government is forced in an area like this to rely on expert advice?
It can choose to use expert advice, or it can choose to go its own way.
Well, you can choose a wide variety of expert advice or just a narrow variety of expert advice. I mean, GPs are the expert in viral respiratory illnesses, and GPs in general were not consulted.
Fine, but if it turns out that incorrect advice was given to government, we can't blame the decision makers for that, can we?
Well, that's not for us to answer that.
But it is for us to answer that because we've been asked to review key decisions made by government. So that's why I'm putting this to you.
Sure.
Is it a fault at the top level of decision making, or in your view, is it a fault by people who were advising government?
Well,
if the incorrect advice has been given, then it's the people who've given the incorrect advice that's the problem.
And as we explained, if I could just answer in our submission, what was unique about the decision-making process and the quality of those decisions this time round, it seems, was the unprecedented nature of the panic and the messaging and the use of fear as a tool. And of course, when you're frightened, logic goes out the window.
Just pause there. That doesn't deal with the question I'm putting to you, because I'm saying if the government was basing their decisions on advice that was given to them, whether right or wrong, those decisions were not made in bad faith. They were made in accordance with normal decision making at the top level, unless you've got evidence that there was some form of a wrong motive or bad faith involved.
Well, I think you have to consider what the top level is then, because certainly the same chain of decision making, much of it ultimately doing far more harm than good, occurred in other countries in a very similar manner.
Well, we're not talking about other countries, we're talking about New Zealand.
Well, that's my answer. I don't know what the top level is. And you'd have to ask the people themselves exactly what the decision-making process was. But we certainly weren't able to get our concerns.
We couldn't contribute to the decision-making progress.
We've got to keep this, keep a clear record of this, so please don't talk over the top of one another. Now, you've said that, I think you've both said, certainly one of you has said that mRNA vaccines were not a traditional form of vaccine. I've personally read a brief of evidence given by a top UK scientist given to the UK inquiry, in which he said that there's no fundamental difference between traditional vaccines and mRNA.
Completely disagree.
I can understand you may not disagree, but do you accept that there is expert opinion that goes the other way?
Yes.
Well,
we accept that's their opinion.
That's their opinion.
I would wonder how expert that is.
Yes, and how they'd got there. I mean, I'd want to have a discussion with that. I mean, the general public's idea of vaccine, what was given to them under the, labelled a vaccine during COVID, was not a vaccine in any sense that they would have understood a vaccine to be previously.
No vaccine has ever turned all the cells that take up the vaccine into a factory to produce a foreign protein that provokes an immune response and will actually target cells that express that protein on its surface, which is what happens, for immune attack. There's never been a vaccine like that.
All vaccines are designed to produce antibodies?
Yes, but not antibodies against human cells that are making the, you don't normally give a vaccine to turn human cells into factories for spike protein, and then those cells themselves, those human cells, become a target of the immune system. If your heart cells are making spike protein, then your heart cells potentially are a target of your own immune system, and that's how the myocarditis happens.
I'm not going to pretend to be an expert on this topic, but are you able to refer to any, and you may have already done this, so forgive me if I've overlooked it, are you able to refer to any papers from a reliable source which distinguishes mRNA vaccines from traditional vaccines?
Oh, there are numerous papers. I can't off the top of my head give you a name and an author.
Byron Bridle, the Canadian immunologist, vaccine developer, he spoke, didn't he?
Yes, he did.
He will have written and clarified that sort of...
if you can just point out in your submissions, perhaps send us an email to identify where that material is, that would be very helpful.
And we have a New Zealand immunologist who's given affidavits in various cases.
Who's that?
Simon Brown, who I'm sure has covered this already and would be able to assist further.
Now, you've indicated that there are a very large number of studies. I think you mentioned a figure of 2 million studies. Do you accept that the safety and efficacy of the various vaccines that we used against COVID are a matter of now great debate and dispute?
Well, from our point of view, there is not much dispute. That there's unprecedented levels of harm. There have been deaths, there have been disability, and the moment there was the first, we've had 5 deaths where ACC has paid out a benefit. There were nearly 70,000 reports to CALM. 20,000 of those were serious adverse effects. So this is the sort of data actually that matters. The moment the first injuries started happening, then there was clearly a knowledge within government that there were some harms. And to continue in the face of, likely further deaths and injuries and disability is far more, it's egregious, and somebody needs to account for that. This is the sort of data that we should actually be looking at rather than arguing about this study or that sort of study.
But you surely must accept that there is a fundamental and difficult question about causation in this area.
Yes.
Well, all of the Bradford Hill criteria are satisfied, actually, and as long as the people that we're asking questions and sending data to refuse to engage and remain silent, do not tell us why we're wrong, do not tell us why they're ignoring the elephant in the room. Yes, please do.
So just with regard to causality, I've been helping a number of people with their ACC claims, and obviously with ACC you have to prove that the vaccine is the cause. I have suggested that people go back to CALM. They've reported their adverse event to CALM, the Centre for Adverse Reactions Monitoring. I've asked them to get CALM to provide them with the causality assessment so that they know what CALM thought. Now, as a GP, I assumed that when somebody reported an adverse event to CALM, the people at the other end receiving them would gather the medical notes. They'd ring up the person and talk to the person, find out the story. They'd get the medical notes and maybe talk to the GP and find out, and then they'd go through either the Bradford Hill criteria, or there's WHO criteria, or there's Naranjo criteria. There's various different ways that you can assess causality. And they'd come up with yes, I think this is highly likely to be caused by the vaccine, or this is not caused by the vaccine, or this may be. Not a single person that I've suggested to go to CALM has managed to get anything that remotely resembles a causality assessment. They get told, the coroner decides the cause of death. And I'm thinking, well, that wasn't the question that the person asked. The person asked, did you think the vaccine caused the death? It doesn't seem that there's anybody, that when people have asked and tried to get hold of that information for their personal ACC claim, it goes round in a circle. Nobody is ultimately determining that causality. And just with regards to CALM doing that, normally they would get 3,000 to 5,000 adverse event reports for all medicines in a year. And in the first year, in 2021, there were 58,000 reports for just one medicine. So, I can't see how they could possibly do a proper causality assessment for 58,000.
Well, surely you must accept that COVID and COVID vaccines were the intense subject of public focus at that time, so that's going to influence the number of people who respond to pharmacovigilance issues.
It might, but equally, it might be genuine harms.
Yes, but
and unless you investigate that, and you consider that possibility, and a fraction only of the serious injury reports that were received were ever actually considered by the independent safety monitoring boards that met monthly.
Right, but
Well, yes. I mean, we've given you an example or directed you to on our website the story of a 30-year-old gentleman who died 25 days after his vaccine. The Independent Safety Monitoring Board, in writing, in their communications, have said we didn't assess his death. He died.
We are not failing to accept that there are some people who have suffered harm, because that's now very well established in the areas of myocarditis and pericarditis. It's the extent of the harm, it's the extent of it's the causation issue and the extent to which vaccines have caused harm that is the big issue for the Commission. And so,
well, it's not an argument for us. We're very, very clear that there are significant harms. Of course, we don't know how many, but we look and we see the mechanisms that would normally identify and engage with that, turning away or being derailed or dismantled. And a great example was the amendments to the Coroner's Act. A coroner no longer has to consider or discover the circumstances surrounding a natural cause of death.
I'm going to have to interrupt you there. We've run out of time, but we're very, very grateful for your contributions, and you can rest assured that we will think seriously about the issues that you've raised and will include those findings in our final report. Thank you.
Thank you very much.
We will go into recess now. We will resume at 2:45 p.m. We will then have a witness for up to 45 minutes, and we will then take another 15-minute break.